Good morning. Shall we begin? Good morning. Good evening. Shall we begin?
Yeah, let's start.
Start now. Hold on. Okay. Wait lang. I just want to make sure I'm pretty. Okay. Good evening, everybody. Good evening, Genesis. Hi. It's nice to see you guys again after a long time. Tonight, we're going to do our pediatric Guazon sessions. And with us tonight are our esteemed doctors and consultants and our doctor student for the night, si Dr. Vince. Now let's begin. Shall we begin? Let's para we don't teeter along or loiter along. Let's begin already. Let's open with a prayer. Let's put ourselves in the presence of the Lord in the name of the Father, the Son, the Holy Spirit. Amen. Lord, we thank you for this opportunity to gather again and have a meeting of brilliant minds to talk about pediatrics. We hope that the students that will listen to this and will learn from this be very good doctors to children. We ask that you we ask that you open their minds to learn and to imbibe all the information that they will receive from this session. We hope that they can use it in the future. And we hope that the doctors that will listen and be part of this session be guided and be protected by your good grace. All this we ask through Christ our Lord. Amen. In the name of the Father, Son, and the Holy Spirit. Good evening, everybody. Okay, will I be the one to introduce, or shall I throw the floor on to Dr. Tiongson? Dr. Tiongson?
Thank you, Dr. Lim. Thank you, Dr. Rocky, for the for the prayer and intro. Again, to our Genesis students, good evening to everyone. Happy New Year, Happy Three Kings. Let's start the year right by doing things right. Anyway, this is your second live Genesis session. For this session, we're going to discuss a very interesting topic. Of course, together with me are the panel of consultants and experts. Again, let me introduce myself. Again, I'm Dr. Mark Denver Tiongson. I'm an internal medicine specialist, adult cardiology and interventional cardiologist, and I'll be your moderator for tonight. And here with me is, of course, Dr. Enrico Paulo Bonzuela to give us some insights on the basic, to correlate the case on our basic clinical sciences. And we have of course, your pediatric lecturers, Dr. Ian De Vera and Dr. B. Punungbayan. Dr. Ian De Vera is one of the big bosses of the De Vera Medical Group, in Isabela. He's practicing as a general pediatrician, and of course, at a very young career of his, is very successful already. And of course, our main consultant, our expert on pediatric emergency cases, Dr. Ruby Punungbayan. She's also a pediatrician practicing at St. Luke's Medical Center, as well as Pamantasan Luzon, Maynila. And then also she's a consultant at the Philippine General Hospital. Without any further ado, we'll begin the discussion. And sorry, of course, let me introduce our student participant for tonight, our ideal dummy student, Dr. Prince Rubio, who is also doing his training in internal medicine. So just to give you an overview on what's going to happen for tonight, for some of you who haven't experienced Guazon, it's actually a case-based discussion where we discuss the history, the physical examination of a case, correlating it with the differential, discussing the differentials, correlating it with the basic pathophysiologic mechanisms, what's the physiology, the pathology behind it, and then after which we're going, based on the top differentials, we're going to discuss on how to approach, in terms of working up the case, on how we'll able to clinch in the diagnosis, as well as formally after doing the labs, we're going to discuss on how to manage cases such as. Okay, without any further ado, everybody, any initial words from Dr. Broly before we formally begin?
Okay, you've had the Guazon before in IM, so we're now doing it in PEDIA. We have a Guazon sessions also for OB and for surgery. Dr. Prince Rubio was chosen for this kasi kahit noon pa, since we started with Genesis 1, si Prince na yung parang namin, pretend student. At that time, katatapos lang niya ng internship. So ngayon medyo nagigain na siya ng knowledge at ng experience on how to be the ideal student, okay, when it comes to the Guazon sessions. What we want you to do, okay, what we want you to learn from these sessions is that, halimbawa kayo na yung mag-represent, whether as a clerk, as an intern, or as a resident, ganito dapat mag-present. Tapos pag kayo na yung residente or consultant, ganito dapat manoksik academic-wise pagdating sa mga presentations na ganito. There's a lot of bullying, there's a lot of ego tripping sometimes that occurs. Pagdating sa mga conferences na to, I always believe that you keep things professional, you keep things educational, and the goal is always for the learning of everyone. So set the ego aside, okay? And then let everyone try to learn as best as they can, learn from the experiences. So, I would like to invite everyone here, even those na nandun sa live stream or ask questions. Yung mga parts na hindi nyo maintindihan dito sa case na ganito na ito, you'll probably encounter a similar case in your clerkship, internship, residency. Sulitin nyo na, magtanong kayo ng questions. You can place your questions in the chat box. You can actually unmute yourself and ask anytime. Okay? Questions that you may have for our consultants. We have two very good pediatricians here, Ian De Vera and Dr. Ruby Punongbayan. Those are PEDIA Platinum authors. Those are virtually gods na rin. Okay, when it comes to pediatrics. They're very, very good in their field. They're very, very good teachers. You're going to meet them eventually once the review for the board exams comes around, the season for that. So maximize the time that you have with them. This is a live session. It's going to be recorded for those who are not present for today. And you can rewatch it anytime. But of course, it's best na kung live session yan, may opportunity ako magtanong ng live, I ask, take advantage. Okay? So let's, Denver, sa'yo na.
Thanks, Brad. All right. Again, good evening. I hope everyone is alive and kicking the start of the year. So to start off, let's have our case. So we have a case of patient KR, a 3-year-old male, Filipino Catholic, from San Juan City, who came in for consultation for the first time in the emergency room for difficulty of breathing. Our informant for this case is her mother with 90% reliability. So history started 3 days prior to consult. The patient started to experience occasional cough, accompanied by colds and undocumented fever. Patient is noted to be active and has good oral intake. There are no vomiting episodes noted. His mother gave the patient an oral decongestant every 8 hours for 3 doses. No consultation was done at that time. 2 days prior to consult, patient developed, the cough became more frequent, disturbing his sleep at night, and had a fever already from 38 to 38.5 degrees Celsius. The fever responded or was lysed with paracetamol, which the mother also gave at 3 ml using a 250 per 5 preparation. He's had a good oral intake and good activity. 1 day prior to consult, patient's condition persisted with notable nighttime coughing, colds, and intermittent fever. KR was noted to have decreased appetite and described to be less playful. And then few minutes prior to consult, patient's temperature was noted to be 39 degrees Celsius and was seen to have fast breathing. So takipnik. His mother brought him to the ER immediately. Upon arrival at the ER, on general survey, the patient had no pallor, no jaundice, no headache, no seizure, no orthopnea, no chest pain discomfort, no diarrhea, vomiting, constipation. There were no changes in frequency of urination or hematuria. There were no tremors. There are no easy bruisability or gum bleeding. Next. On maternal history, the patient was born to a 25-year-old G1P1 1001 mother who's a non-smoker, non-alcoholic beverage drinker. Mother had a regular prenatal checkup at the local health center starting at 2 months age of gestation. Mother had intake of vitamins and ferrous sulfate throughout the duration of pregnancy. There were no maternal illnesses, no exposure to teratogens, radiation, or viral exanthem. Ultrasound during prenatal was done on the 5th and 8th month of gestation, revealing essentially normal findings. Patient was delivered to a full term via NSD at a local government hospital, assisted by OBGYN specialist. Patient had good cry and activity upon birth, no cord coil and meconium stained amniotic fluid. Birth weight was 2,900 grams. Newborn screening was done, revealing normal results. The patient passed his newborn hearing screening and test as well. Mother and patient were discharged after 24 hours. And nutritional history, patient was exclusively breastfed for 6 months. Breastfeeding was continued up to 2 years of age. Complementary feeding was initiated at 6 months. Currently, patient eats regular food and prefers eating preserved foods like hot dogs, canned goods, eggs, and rice. There's only occasional intake of vegetables or fruits. No known history or allergy to food or drugs. On immunization, patient has 1 dose of BCG, 4 doses of hepatitis B, DPT, OPV, or 3 doses each. HIV vaccine, were 3 doses, measles, 1 dose, and MMR, 1 dose. Growth and developmental history, he has normal growth, fine motor, language, and social developmental history. Family history is the patient's father is a 30-year-old call center agent, while the mother is a 28-year-old housewife. On past medical history, the patient was admitted at a 1-year-old with unrecalled diagnosis, but informant remembered that there was fast breathing and an audible breath sound during the patient's illness. There were 3 other episodes of nocturnal cough and colds for the past year, but patient was not admitted. The mother just used salbutamol to nebulize her son at home using a face mask, which afforded relief. There were no consultation with the doctor for these instances. The patient lives in a well-ventilated house with his parents and his maternal grandfather. Garbage is collected regularly. Source of water is from Maynilad, but the drinking water is purchased nearby water filling station. His maternal grandfather occasionally smokes inside the house. There are no family members with communicable diseases, and there's no history of recent travel. Before I proceed with the physical examination, Dr. Rubio, can you, for our students, can you just highlight what are the pertinence for our patient KR?
So, good evening to all of you. I am Dr. Rubio. So, we have here a case of a 3-year-old pediatric patient coming at the ER due to difficulty of breathing. So, patient had a 3-day history of having cough, having undocumented fever. At the same time, patient eventually presented to be having poor appetite and weak looking. And clinically wise, objective assessment of the patient has tachypnea and is shown to have sorry, basa yung ano. Can you go back to the objective assessment of the patient? Sorry.
No, ano lang, friends, just pertinent
Okay,
lang for the history of present illness.
Okay, so for the patient, it's important to take note that the patient had a history of undocumented fever, that's one, fitting for infection, cough and colds for the patient as well. And you should take note that the patient has decreasing appetite over the past 3 days, which is very important for the pediatric population. And moreover, for the patient's past medical history and birth maternal history, they are both unremarkable for the patient. But it's notable that the patient already had a previous incident back in the days when patient had a history of an incident also having difficulty breathing and was hospitalized back then. So this is actually pertinent. And take note that the patient had these symptoms most of the time at nighttime.
So Dr. Rubio, given the patient's history, if you were the first doctor, even if you're not a pediatrician, as a doctor, what are your thoughts? What could have been happening to our patient?
Mainly seeing a patient to be dyspneic, I would first determine its chronicity, if it's acute or chronic. In this case, it happened over the past 3 days. So I'm thinking of a condition that could be more acute in nature than a chronic problem. So therefore, I'll think of problems that would include one, could be pneumonia, since patient had a history of fever as well and decreasing appetite over the past 3 days. I would also think of a possible foreign body aspiration. However, it is more acute in presentation and patient will be more toxic looking. I would also think of a possible trigger for asthma, since a patient had these symptoms usually occurring at nighttime. And if every patient has a viral infections are also known to be triggers for asthma. So these are my possible differentials at the top of my head right now. since chronic problems, including cyanotic heart diseases, wouldn't be much of a problem since they are more chronic and they would present with more problematic problems such as cyanosis and failure to thrive over the past years.
Dr. Punong Bayan, can you, as an emergency consultant, can you give some comments with regards to the thoughts of Dr. Rubio?
Hi, good evening, everyone. Yes, very important as I have worked in the ER as a PEDIA emergency specialist since 2003 up to present. So any child or infant or even adolescent coming in with fast breathing and or any form of respiratory distress, very, very important as what Dr. Frins has pointed out, what has been the presentation. Are you looking at an acute problem or chronic? And then it is also very important to take note of the accompanying symptoms. Is it just fever, cough, colds, or were there in the course of the illness down to the day of consultation, were there any other new symptom that has risen prior to, like few hours prior to consultation, no, additional symptoms pointing to respiratory distress again? And very important, tinatanong namin, meron na bang mga gamot na binigay? Okay. Like paracetamol, what has been given as a temporary relief for the patient. And Dr. Frins also pointed out, no, na from as you are getting the history, of course, very important in the past medical history, were there any other similar conditions? Okay, like meron na ba siyang prior hospitalization revolving around respiratory problem? Was it what was it? Sometimes parents are so anxious so that hindi nila naaalala kung was it really pneumonia or any other problem. So dapat ma-elicit yun. Dapat ma-elicit yon during history taking. Again, any information that you get under the past medical history may tie up, may correlate with the current problem, or it may not be related after all. So ito yung tinatawag nating pertinent positive information and pertinent negative information. And by the way, pag may cough and colds, lagi-lagi kong pinapatanong sa resident, sa intern, sa clerk, ano ang time niya? Is it any day, any time of the day inuubo? Is it during night time? Is it disturbing the sleep? Awakens the child at night? All of these are vital information. So please remember all of those important tips with you. Kasi ganyan ang mga itatanong namin actually. Okay. Back to you, Dr. Denver.
Thank you, Dr. Ruby. No? Very important, the timing of cough. Kasi nga, there are certain conditions, no, that are associated with those timing. And Dr. Ian De Vera, if you in your practice, no, when you get such cases with this kind of history, what do you usually think or do or for further probe?
Yeah. So yeah, most of the important clear ba ako? Narinig ba ako?
Yeah. Go ahead.
So yeah, most of the important points have been mentioned already by Doc Frins and Doc Ruby. So yeah, you have here a 3-year-old. So pag ako usually when I have patients like this na in distress, yun nga, ang lagi nyong kailangan tignan is to see if this is an acute problem versus something na recurrent or chronic. Kasi that would make a lot of difference in your differential diagnosis as well as your management. So yung batang nagkasakit na acutely versus yung bata na buwan-buwan pa lang may ubo, ibang-iba yung sakit na iisipin nyo compared dun sa ganitong case na yung patient natin 3 days lang yung cough niya tapos nagdi-distress na siya. And also yung progression is very important. Yung patient na, for example, 1 week na nag-uubo sipon before na ang dami nang nainom na gamot, nag-consult na sa iba't ibang doktor, before coming into the emergency room in distress, ibang sakit din yung iisipin mo compared to this case na 3 days pa lang. So medyo mas mabilis yung progression nito. 3 days pa lang to, tapos in distress na siya. So you would think of probably on top of my head, if I were, although ito hindi to 100% of the time, pero if you were dealing with the common flu, the common viral illnesses in children, which majority of cough and colds in children are caused by viruses. If you're dealing with those pathogens, you would expect na yung course niya medyo mas mabagal as compared to a bacterial cause of pneumonia or respiratory tract infection na ganito, 3 days pa lang in distress na siya. So it's either that, either pangit na pathogen or baka naman pala this child has an underlying problem. Baka nabanggit difference, baka may cardiac disease pala siya, kaya simpleng pneumonia lang, distress na siya. Or baka pala may asthma siya na na-trigger ng infection, kaya konting 3 araw pa lang in distress na siya. So all of those factors are very important. That's why, yun, when you look at the history of the child, you have to, sabi nga ni Dr. Ruby, look way past what's happening right now, dig deeper, tignan nyo kung ano yung mga nangyari sa past medical niya, sa family history niya, and then correlate. You have to synthesize and see if those informations are pertinent or not for your case.
Okay, thank you very much, Dr. De Vera. I mean, as moderating, as an adult specialist no moderating ng PEDIA, I'm still learning a lot from how things are managed differently in a pediatric patient. Looking at the history kasi, there are lots of parts of the history that are actually included that in the adult history we don't usually elicit anymore, like the nutritional, the immunization. At times we don't discuss that anymore. These are some of the peculiar differences in terms of history taking in a pediatric population, because as Dr. De Vera, as Dr. Punangbayan, and Dr. Rubio has pointed out, there are very important details that in these different parts of the pediatric history that you have to look into in order for us to be able to clinch a diagnosis. Because more often than not, the problem with the pediatric patient is that they cannot give the information voluntarily on their own, so there's another informant, like in this case the mother. So that's the reason why I think there are several parts of the history which are needed in order for us to get the diagnosis. And one of the highlights lang, just to emphasize to our students that I got, is that first you have to determine the chronicity or the acuteness of an illness, whether is it acute or chronic. From Dr. Punumbayan, she has highlighted that the timing of the symptoms, whether night or day, what are the triggers, are very important for us to be able to clinch in the diagnosis for our patient. Okay, so going back to the case, we're already in the physical examination. So we are given with the patient with a 3-day history of progressive cough associated with difficulty of breathing, associated with fever. So we are more likely pointing to an infectious cause, which, as discussed by Dr. Rubio, could be a pneumonia with an underlying asthma, as highlighted by Dr. De Vera. Now, looking at the physical examination of this patient, when the patient appears awake, irritable, in distress, the weight is 15 kilos with a C-score of 0. Vital signs patient is 110 with a RR of 55. That's really fast, with a BP of 90/60 and a fever of 38 degrees Celsius with a O2 sats of 93%. There are no skin problems. On HENT, there is anectatic exterior, there's pain, palpebral conjunctivate with watery nasal discharge, no ear discharge with ear flaring. The patient has grossly normal ear, intact tympanic membrane in both ears, dry lips, non-hyperemic posterior pharyngeal wall, no oral lesions, no cervical lymphadenopathy, supple neck. And chest and lungs, there's symmetric chest expansion with subcostal and intercostal retractions with occasional wheezing in both lower lung fields with rals on right and left mid to lower lung fields. The heart is on cardiac P, there is a dynamic procordium, distinct heart sounds, regular rhythm with a point of maximal impulse at fourth ICS, left mid clavicular line, no murmurs. The abdomen is flat, normal. The bowel signs are normal active, tympanitic, on percussion, non-tender, no masses, no organomegaly. Pulses are full and equal with capillary refill time of less than 2 seconds, non-cyanotic nail bed. So before we see Prince, Dr. Rubio, now given your history and physical examination findings, what is now your working impression, or what are your differentials?
So for my differential, now more focusing on a respiratory problem. So I'm currently now excluding a cardiac problem in this case, since as mentioned in the P of the patient, it is less likely because patient has not any the salient features of having a congenital heart disease, including cyanosis. There's no failure to thrive present, and there are also no distinct murmurs present for the patient. Given this case, I'm focusing more on pulmonary problem. This could be a case of pediatric community-acquired pneumonia. Since the patient here is presenting with a history of cough, history of fever, having tachypnea, having reactive tachycardia to distress, and it's notable in the patient's case that has respiratory distress. There are retractions present in the patient's chest examination. There is actually mentioning of alar flaring, which is actually a sign of respiratory distress, especially in the pediatric population. And this retraction is also present. There is also the examination. But I wouldn't, but since this patient also mentioned to have a previous problem as well, there is also noted of wheezing in this patient. Wheezing is not a common, but rather a salient feature of asthma. And in the pediatric population, we don't really perform pulmonary function testing since they are not cooperative, but asthma can be clinically diagnosed in the pediatric population. So and asthma can also be a consideration in this case. And at the same time, those would be my primary working impression. This could be a case of PCAP with underlying bronchial asthma in acute exacerbation. Being triggered the patient having PCAP. But in the history, there could be also an underlying upper respiratory tract infection since patient has rhinorrhea, and that could have triggered the patient having asthma as well. So for my other differentials mentioned, as mentioned, cardiac problems less likely in this case. I would also like to determine that the patient would also have, it's also less likely to have upper airway obstruction since there's no stridor present. There's no mention in the history of having an exposure to a foreign body that could have displaced in the patient's upper trachea. So those would be my differentials and primary working impression.
Okay, so that those are actually, so in my perspective, those are actually solid differentials, pediatric community-acquired pneumonia on top of possible bronchial asthma in acute exacerbation. Just to you're really leaning towards a cardiac problem to exclude, as a cardiologist. What are the usual, in the birth and developmental history of a patient with a cardiac congenital problem? And what are the usual things that you look for? Kasi lagi mong napabansin kanina Lagi mo na may mention yung cardiac problem o congenital problem. But how does usually patients with a cardiac problem present, no?
So in the pediatric population, especially those having cyanotic heart disease, so bata pa lang sila, they would usually have this failure to thrive symptoms. They're usually very small compared to their counterparts. At the same time, they have poor nutrition. They have recurrent infections since they have poor nutrition, which could also lead to poor immunological defenses for the body. Patient would also have cyanosis as mentioned, so we should check for the patient's pallor if meron siya sa kanyang peripheral as well as central pallor present. At the same time, these patients would also be seen to have clubbing of the patient's distal extremities as well. So those are salient features of patients having cardiac problem. Okay. Mainly those with congenital heart problems.
Okay, very good. No? Actually, the pertinent is infrequent upper respiratory tract infections. Just before we proceed to the more salient differentials, is the one that I've noticed in history is that there is a previous history of similar problem before. Can that be can that incident, yung history niya sa past medical history, that there's a similar incident that happened a few years back, can that be a sign that it is a cardiac problem? If you haven't known the history of the patient, I mean the condition of the patient.
Given the case, I would think that it is still not cardiac in origin, since when we say about recurrence of pneumonia, this would usually occur having at least 2 pneumonias per year. And actually more frequent. So in the patient's history, this could have been another case of early onset asthma or even pneumonia. Then it being a cardiac problem. And given the patient's condition, patient is actually clinically well prior to the patient having the symptoms. So on a larger scale, there are actually no chronic symptoms present for the patient.
Okay. Just to ano lang no, just to have a quick remark. The most common kasi congenital heart diseases are ASD and VSD, no. The one persisting to up to adulthood is usually the ASD. And this usually presents with recurrent upper respiratory tract infection, and of course easy fatigability. Yun nga, very important sa personal social history ng mga patients na hindi sila masyadong nakakasabay makipaglaro. Mas madali silang mapagod. Kapag ina-elicit nyo to guys sa mga patients niyo, you always ask the mother or the patient na parang mas madali bang mapagod yung anak po ninyo compared sa mga kalaro nila. So these are subtle signs that you can ask for patients na may congenital heart diseases na usually acyanotic in nature. Now going to the pertinent parts of the case, Dr. De Vera, do you agree with Dr. Rubio's impression?
Yeah. So given the presentation, I would probably at this point agree with the differentials and the impression presented by Dr. Rubio. So probably I wouldn't be considering something na chronic at this point. Very important din guys, remember for PEDIA patients is the anthropometrics. Kaya lagi nating ginagawa sa OPD yan, di ba? You're measuring the height, the weight. Because aside from yung playfulness, aside from the activity, limitations of the activities of daily living, a lot of times yung mga chronic diseases sa bata, they would manifest sa anthropometrics, dun sa mga measurements ng bata, sa height, sa weight, okay? Lalo na kapag yung mga chronic diseases, ang tatamaan niyan mostly would be yung sa weight for the length of the patient. So magtataka kayo, you have a child na kumakain, magaling kumain, tapos walang history of hospitalization, but then when you look at the weight for height, papasok siya sa wasting. I get a lot of patients like that na hindi sila failure to thrive, hindi sila nag-grow, and then lo and behold, pag auscultate mo may murmur. Tapos pag check mo, VSD, ASD pala, in cardiac failure na pala yung patient. So you have to watch out for that. But for this case, yeah, I would think that this is probably an acute illness. Although yung feature niya na nagkaroon siya ng ng recurrent cough at night, nasa question mark pa yan. At this point, we cannot rule out asthma. So probably in the discussion later, Dr. Ruby and I might give you tips on how we differentiate asthma, patient having asthma versus that na may pneumonia na may asthma versus asthma lang pala talaga. So one of the things na palaging na-encounter in practice yan, and it's not as straightforward, hindi siya ganun kadali, pero there are guidelines that you can follow. Kasi lagi namin sinasabi yan, tinuturo palagi yan even in residency na not all that wheezes sa mga bata is asthma, and not all asthma will wheeze. So medyo unlike in adults na you can go to spirometry, tapos mas madali siyang i-diagnose, sa bata medyo mas tricky. Kaya at this point, yeah, I agree. This probably looks like pneumonia. Whether the patient has asthma or not is still a question mark.
Dr. Ruby?
Yes, I agree. I agree with Dr. Friens. I appreciate yung naging line of thinking niya na nag-come up doon sa kanyang present working impression. Just because as of now, ang meron lang siyang data, history, and PE. What he did was to get the highlights of the history, kinorelate sa PE, and he was able to point out yung signs of respiratory distress, na emphasize niya na maganda ang weight ng bata, again, which means unlikely nga na mayroong ibang underlying comorbidity, yun ngang nababanggit niya na a possible congenital heart problem that could also explain the respiratory infection dahil nga Z-score of 0 within normal, a 3-year-old is 15 kilos. So based on the mnemonic age in years times 2 plus 8 for 1 to 6 years old. So quickly 3-year-old patient, 3 times 2 plus 6. So more or less 14 kilos, 15 kilos. Alam na alam agad natin na, yeah, maganda ang timbang. Now, dun sa mga signs of distress, na-appreciate ko, dapat ganun ang line of thinking ng interns and clerks, wherein na-identify nila yung abnormal breath sound, whether it is that abnormal breath sound indicative of upper airway obstruction, or is that abnormal breath sound that you are hearing indicative of lower airway obstruction. Kaya na pagdugtong niya, na correlate niya, and then he came up with that admitting diagnosis, which Dr. Ian and I agree. And lastly, isa pang importante, no, in relation with Dr. Denver's comment kanina, no, sa having a possible congenital heart problem. For older children, sa ROS, pag nagtatanong kayo, yung madali ba siyang mapagod in comparison with the peers, with the classmates, nag-PPE, madaling mapagod, that's an important clue indeed, no? For infants, one good question to determine easy fatigability. Ano bang ginagawa ng infant? Kain, tulog, dede. So, paano nalalaman na napapagod? Interrupted feeding. Madaling mapagod. Dede, whether breastfed or bottle fed, nakalatch. Napapagod. Dok, parang humihinto in between, pero hindi pa siya tapos dumede. Tapos magre-resume. Tapos parang nahihingal, hihinto. Tapos dede na naman. That's a clue. In other words, concentrate on feeding history. Kumusta po siya dumede? Tuloy-tuloy po ba? Tapos titingnan nyo ngayon, maganda ba ang weight? Baksak ang weight. So, those are clues agad. Malalaman nyo, ay para po siyang napapagod, humihinto-hinto, dumede. This is of course for infant age group. Okay? So, that's it for now. Back to you again.
Pwede may dadagdag.
Go ahead, Dr. Rivera.
Yeah. For the benefits of the students, so during the PE, we saw that the patient has a respiratory rate of 55 for a 3-year-old, and yes, sabi nga ni Dr. Denver, mataas yan. Dr. Fritz, naalala mo pa ba yung yung cut-off natin for the upper limit ng RR sa age group sa mga bata?
Hindi ko na alam specific. Alam ko lang yung for guidelines wise, yun yung naalala ko. Pero yun sa mga bata in general, hindi masyado. Basta ang alam ko lang for those patients na 3 to 12 months, dapat less than 50 siya dapat per minute.
Yeah, alright.
Those who are 1 to 5 years, dapat less than 40 siya. And those more than 5 years, dapat less than 30 dapat.
Yeah.
Parang
okay, so so tama yun. Dagdagan lang natin for the benefit of the students. So I always teach this to the students, to the nurses, in our institution. There's a very easy way to remember the upper limit of respiratory rate for children. So you start with 60. So 60, 40, 50, 30, 20. So newborn is 60, ang upper limit nyo. So that's 0 to 3 months. So newborn is 60, up to 1-year-old is 50. Tapos, di ba, 55. So up to 5, 1 to 5 is 40. Tapos 5 to, dati 10 eh. Pero some guidelines ngayon in-extend nila to 12. So 6 to 10 or 6 to 12 up to adolescent is 30. And then yung adult is 20. So madaling tandaan, di ba? So 60, 50, 40, 30, 20. So newborn, 1-year-old, 5 years old, 12 years old, tapos adult. So yun yung cut-off nyo. So pwede nyo ilagay sa mga interns, lagay nyo sa kodigo nyo yan para during rounds, may idea kayo kung yung pasyente nyo ba is takipnik depending on the age group.
Okay, at this point in time, no, napansin ko lang hindi na consider kasi still we're not yet out of the pandemic. Can the patient can COVID be still considered for this case?
Yes, actually patient that's presenting with whitish secretions, nasal discharges. So pwedeng meron siyang upper respiratory tract infection, And this could be of different etiology. It could be your common cold from the rhinoviruses, can be from your measles virus as well. Pwede rin coronavirus. Actually, coronavirus is actually one of the most common group of viruses causing common colds. So, pwede naman talaga.
Yeah. And then, di ba? And then because patient has respiratory, the fact that the patient has respiratory tract infection, the patient likely, most
Yes.
can at least we have to if it's not top of your differential, at least rule out COVID. Oh, yan. All right. So our admitting impression for this patient is pneumonia, community acquired, severe, to consider asthma in acute exacerbation, COVID probable. So, given this admitting diagnosis, doc, friends, what are the labs that you would request for this patient?
So for the patient's initial laboratories, one, definitely we need to perform the patient on chest X-ray. Chest X-ray would rule out a lot of etiologies for the patient. We can check for the patient's cardiac size and silhouette. Cardiac-wise, you can have different problems. You can have different morphology as well. There are same morphologies for different cyanotic heart problems. Moreover, you can, of course, you can check the patient's lung parenchyma. If there are any problems involved, and you can see some complications that can be caused by pneumonia, like abscesses for one. You can see even pneumothorax as well if they're present. So we can rule out a lot of things with just X-ray. Next thing is to perform a complete blood count. ACBC is very important here. You can check the patient's hemoglobin level. If patient's anemic as well, we can provide support for that. We can also provide information for WBC count. Having leukocytosis, you can check the patient's baseline's WBC count. And over time, it can be used for monitoring for response eventually. For the WBC of the patient, if there's predominance of neutrophils, so it will actually increase the likelihood of patient having bacterial pneumonia. So these are very important parameters. Since the patient is having tachypnea, in this case, an ABG is also warranted. We need to know the patient's acid-base balance. And having tachypnea will actually confer a possibility of having respiratory alkalosis. So that could be a primary metabolic problem here, which we was much out for. Besides those things, those are the salient ones. We may also, if possible, that the patient can be able to expectorate sputum. We can perform a sputum GSCS, would actually help us in providing information. In terms of days of blood CS would actually have a low likelihood of having a growth. So blood CS isn't not, well, in practice, even in adult patients, blood CS would have a low yield of determining a bacterial problem or elucidating an etiologic agent. So I would lean more to a sputum GSCS than a blood CS. We could also use some parameters that would also help us. These are actually surrogate markers such as procalcitonin, can help us in determining the etiology if it's bacterial or not. And if you have high procalcitonin level, it's actually also warranted for an antibiotic treatment in the pediatric population. Although in adult practice, procalcitonin is mainly used for step-in for antibiotics. It can also be used to elucidate the etiology of the patient if it's bacterial or not. But in this case, in the PEDIA population, per guidelines, procalcitonin has benefit in this case. So those are my primary
How about
those were,
electrolytes? Want to check for
yes,
the
eventually. That was what about to say. Those are my primary tools for the differential diagnosis. But we need to perform also some ancillary tests that would help. That is important. This patient has poor oral intake over the past days, so we must check for electrolytes, creatinine levels, and BUN. Since we must check for the patient's kidney function if or an having hypokalemia, hypomagnesemia as well for the patient. And furthermore, it's also warranted. Yeah, those are the things we must perform actually. So yung iba talaga, those are the tests for differential diagnosis, iba for ancillary testing.
Before I get some comments from Dr. Punong Bayan and Dr. Rivera. If the patient syempre, of course, those are the ideal. What if you are limited to top 3 laboratories that you would request? Which are these top 3 laboratories and why?
I would perform a chest X-ray because you can rule out a lot of things in chest X-ray, and CBC, and I would ask for preterm GSES because we can perform here after empiric treatment. If there's growth in the patient's culture, we may be able to narrow down our therapeutic regimen for the patient's pneumonia if present.
Okay, we'll see if our pediatricians would agree. Lastly, would you request for spot check of sugar, CBG, for this patient?
Yes, it's also important since patient has poor oral intake. Spot CBG is also warranted as well.
See. All right. Doctors, I'll call on first Dr. Panumbayan. Ma'am Ruby, do you agree with the workup requested done by Dr. Rubio?
Yes, actually extensive na, no? And it looks like it has adhered to the 2021 PAPP guidelines, that of Philippine Academy of Pediatric Pulmonology guidelines, no? And gusto ko yung tanong mo, top 3 sa mga resource challenge institutions. Mahalaga yan. Very practical question. Although, with regards to sputum GSCS, considering the age, again, your patient is just 3 years old, you may have a difficult time getting a sample because they don't easily and readily, expectorate cough out. But sometimes, hindi voluntarily, unlike older children and adolescents. Pero kung sputum na halimbawa post-tussive vomiting, tapos na kasi yun na trigger ng kakaubo, tas nag-vomit, it may not be that good a specimen and very sensitive to, to be able for us to isolate kung galing lang sa post-tussive vomiting. However, if your patient is older, and number 2, if we're talking about very severe cases of pneumonia wherein there was a need eventually to intubate the patient, yon maaari, no? Coming from the tube, no? Pwede yon, GSCS. And in fact, again, mentioned naman talaga sa guidelines. We are just considerate of the age of our patient as to the utility of the other lab tests. But for the rest, yes, of course, CBC, chest X-ray, your inflammatory markers, yes. Kung walang procal sa ospital where you are practicing, CRP would do. Kung wala pa rin talaga, then what could we do? Ano pa ba?
ESR.
Oh, ESR. Yeah. Oh, that's the simpler one. Very basic. And then, of course, chest X-ray. By the way, point of care na talaga. Pag pumasok, no, at least dun sa aming institution, pag pumasok yung bata, nahirapang huminga. De kami naman sa triage, titingnan na, sasalubungin, na-identify, takipnik. Tapos, spot check, 93%. Sabi sa case, O2SAT, room air. Alam mo na yung andun ng distress, nag-ALR flaring, nagre-retract, everything, a quick auscultation. Pasok sa loob, natatanong na agad, di ba? Kasi simultaneously happening to. Ano po nangyari? Ganon. Mahina na bang dumede? CBG. Papa-CBG. So yung importante yun na bring up din ni Dr. Denver. Kasi nga, pangit na yung intake. So we need to correct that in case, it is the CBG is low for age, no? Okay, so that's it for me. Yes, I agree.
All right. How about you, Dr.
Correlate
Go ahead,
things with some of the basic sciences, admitting diagnosis. Itong pneumonia, asthma, COVID, do you consider them obstructive or restrictive lung disease? Give an overview of the two, compare obstructive and restrictive, and discuss kung bakit obstructive or restrictive yung tatlong yan.
So in general, we have actually 2 main pathologies for the pulmonary diseases. We have obstructive diseases and we have restrictive diseases. In obstructive diseases, these are problems wherein there is a problem with airflow, expiration of the air coming from the lungs. Therefore, there's actually air trapping happening. Air is being retained within the lung parenchyma. So these are usually seen in patients with asthma, COPD, bronchiectasis. Those are the salient conditions. And those diseases can be identified ideally with a spirometry. So patients with obstructive lung diseases would have a lesser FEV1 and a decrease in the ratio of FEV1 over the first vital capacity. So in general, we have here that problem. So mas problema tayo with the expiration of the airs coming from the lungs. Now, in restrictive pattern of respiratory problems, these restrictive problems, they are problems with the parenchyma and the patient's respiratory alveolar wall. So in this case, we are having here a decrease in the patient's overall total lung capacity. Since mas restrictive ka, mas compliant ka, hindi masyadong bubuka yung mga airways mo in the process. Kaya restrictive in the process. And mathematically, spirometry-wise, you will have here a decrease in FEV1 as well. But the ratio of the FEV1 decrease and the decrease in FVC are both equal. So you'll have a normal or even higher FEV1 over FVC ratio. That is the mathematical difference of the two conditions. And conditions included in restrictive would include your pulmonary fibrosis. In this case, pneumonia is actually a case of restrictive pattern than an obstructive pattern.
Okay. Dr. Bancela, any follow-up questions?
Okay, that's good. Obstructive versus restrictive. How do you determine whether something is obstructive or restrictive? What test do you use or what criteria do you use, Prince?
As mentioned, we can perform a spirometry test. Spirometry test, it is when we inhale a lot of air and exhale properly a lot of air so that we can check the different volumes of the lungs afterwards. So we have a first means of doing it, inhalation and exhalation. So those would have an obstructive pattern, we have a decrease in FEV1 and a decrease in the ratio of your FEV1, your first expiratory volume in 1 second over the first vital capacity or FVC. So mas decrease yung kanyang ratio. In contrast to your restrictive pattern, you have decreased FEV1 as well, but you have a normal ratio of your FEV1 and FVC or even higher ratio.
Okay, commonly tinatanong kasi sa board exams to for physio and also for patho. So let me refine yung sinabi ni Fritz. FEV1 is forced expiratory volume in 1 second. FVC is forced vital capacity. Obstructive versus restrictive, both FEV1 and FVC will actually decrease. So in both obstructive restrictive, bababa yung FEV1 alone, FVC alone. The difference, the way to differentiate obstructive and restrictive, yung obstructive, bumababa yung FEV1 FVC ratio. Habang yung sa restrictive, yung FEV1 FVC ratio niya normal or tumataas. So paano nangyari yun? Bakit, Prince, pareho naman bumaba FEV1 alone, pareho naman bumaba FVC alone, bakit magkaiba yung FEV1 FVC ratio? Ano yung mathematical explanation?
Mas mataas kasi yung decrease, same magnitude yung decrease ng FEV1 and FVC doon sa ating restrictive pattern. Kaya pag di-ratio mo siya, normal pa rin siya. In contrast sa obstructive pattern natin, greater yung magnitude of decrease ng FEV1 in relation to FVC. Kaya decrease ang FEV1 over FVC ratio ng ating obstructive.
Very good. So in obstructive lung diseases, FEV1 and FVC will both decrease. Pero mas malaki yung binagsak ng numerator, yung FEV1. So mathematically, pag parehong bumaba ang numerator-denominator, pero mas malaki yung pagbagsak ng numerator, bababa yung quotient. Kaya yung FEV1 FVC ratio mo, bumababa. Habang sa restrictive, bumaba yung numerator-denominator, FEV1 FVC, pero mas malaki yung pagbagsak ng denominator, FVC this time. So mathematically, pwedeng either normal yan, parehas lang, or more likely pwedeng magkaroon ng increase. Dahil pag bumaba ang numerator, bumaba denominator, pero mas malaki yung baba ng denominator, ang quotient niyan, surprise, surprise, will actually go up, will actually increase. Thank you very much, Prince. Proceed, Denver.
Okay, thank you.
I would also like to Ano pala, dagdag din pala kay for the diagnostics, since we have COVID probable, RT-PCR also is also warranted for this case.
Okay, good, good. Dr. Ian, any additional lang for the diagnostics?
I would have to agree naman with the diagnostics mentioned by Vince. Yun nga, ideally guys, pag unlimited yung funds nyo, lalo na you have a patient na in distress, mukhang decompensated, then you can do those tests, procalcitonin, mga markers, okay? Ako, if I would be narrowed down to 3 tests din, pwede ko ipagawa din. Yeah, CBC, X-ray, and the third test probably it's either going to be ABG. Might request for a blood gas for this patient, lalo na in severe respiratory distress siya. Either ABG or kung mapipiliin ako ABG or yung isa antigen. Kasi we're trying to rule out COVID at this point, di ba? So from the get-go, you would want to know if you're dealing with someone na kailangan naka-isolate pala, hindi ba yung management. Pero yeah, generally agree.
Alright. Kung actually ako, I agree, no? If we are out of pandemic, kumbaga parang cases of COVID are not that high anymore, no? Ako, I would go for chest X-ray, CBC. Siguro ako would, I agree with Dr. De Vera, ABG, kasi it's really important kasi severe pickup siya. If there are 3, we're limited with finances, no? If ABG is not available, I will just use the pulse oximeter kung DESAT to help me determine if there's an advanced airway that needed. Siguro the third one I would do the creatinine kasi for adult important yan for those adjustments sa medications. Si Ma'am Ruby, kung kayo ma'am, kung may top 3 kayong labs, ano yun sa inyo?
CBC chest X-ray. Yung third ko, depende kung nasaan akong ospital. Kasi pareho namang nagtatrabaho ako sa private tertiary at saka sa government na tertiary. So, yung isip ko ba, depende kung ano yung available sa laboratory. So, pero kasi usually minsan dun sa government, minsan naglolo ko yung ABG machine. So, kahit gusto ko, hindi pwede. So, minsan ganun yung decision mo eh. Ano bang available doon? So, the third one will be ABG/mga COVID tests or yung, anong tawag ito? Mga markers, inflammatory markers. That's it.
All right. Thank you, Doc. I hope you you see how, kasi it's really different what we read in guidelines, what we read in textbooks, but in actual clinical practice, it's very different. Lastly, before we proceed to the diagnostics, I would just like to get the inputs of our pediatricians. We are actually discussing this case in a very ideal manner. But during, particularly kay Dr. Punong Bayan in the ER, when a patient came in respiratory distress, difficulty of breathing, what are the pertinent things that you will look for in the history and what are the focused physical examination findings that you would do in order for you to stabilize the patient? Kasi yun naman yung role natin, very important. Once the patient is at the ER with a symptom complaint, we want to see whether it's life-threatening or not life-threatening. But what are the things that kasi these are, if we're going to do the history and PE this way, it will take us at least 15 to 30 minutes. But given a very limited time and time is of the essence, especially in resuscitating, addressing, stabilizing, what would be the pertinent things that you would just get in the history and the physical examination?
Okay, in real life, pagdating nila sa triage area muna. Okay? So, andun naman kami sa triage usually. So, makikita na, or kunyari, napapasok ka sa loob dahil you are attending to somebody else. Pero the triage nurse, the triage team will definitely call you. Tatawagin kayo kung sino man naka-duty. Doc, may nahihirapang huminga. So, a quick look that, yung nabanggit ko kanina, nagva-vital signs na all are happening all at the same time. Multitasking yan. So habang, sige nga, lift the shirt, tinitingnan ko kung nagre-retract, nag-i-alar flaring. In other words, number 1, vital signs. Number 2, alongside with that, tuloy-tuloy yon, signs of respiratory distress. And then, habang sinasabi, dahil nakita mo, nasasabihin ng nurse, ay doc, baksak O2 SAT, ay RR 55. Okay, fast, low, normal. Identify agad. That's fast. 3 years old. So, tiningnan mo, ay nagre-retract, nag-alar flaring. Habang na-assess mo yon, what? Sa totoong buhay, kaya mong ma-assess yun in 1 minute. Sa totoo lang, 2 minutes. Ihahatid na yan doon. And because the condition is very acute at yan ang signs of distress, we bring the patient, we make her lie down doon sa may bed, tapos nakakabit na dapat doon sa, syempre, oxygen, airway. At habang nangyayari yon, habang wini-wheel in ng pasyente, tinatanong ko na yung mami, yung nanay. Sabihin ko, ano po nangyari? Ilang araw na may sakit. Okay, okay. So, a quick siguro, a minute again. Kasi mabilis lang naman yun. Sasabihin, 3 araw na ho. Okay. Umaga o gabi ang ubo. Whole day ba? Kailan ang huling paracetamol? May iba pa bang gamot na binigay? Okay. Again, another 1 to 2 minutes, nakahiga na yon, tumakbo na yung nurse nyo, kinabitan na siya ng oxygen. Just look for signs of distress. Okay? And the nitty-gritty part, the details, you can always go back. Sa totoong buhay, lalo na ito, no, yung particular scenario na binibigay natin ngayon, no, is happening in the ER. So, at times, you may do your history taking twice, 3 times, because you have to understand all of these patients coming in together with their anxious mothers, anxious parents. Sometimes they forget some details of the history. It is wise to get the history again. Ito nga po pala. Kasi habang ina-attendan mo siya, ina-attend mo yung respiratory distress, hindi ka naman magtatanong agad ng immunization history, right? So once you've stabilized the patient, tsaka mo siya babalikan. Kaya nga merong second round of history taking usually, lalo na sa ER setting. And let me just ask also, friends, no, yung anong gagawin na natin na identify yon, yung mga signs of distress. So what would be an ideal oxygen delivery device for this 3-year-old patient in distress? Para lang ma-share natin, kasi di ba meron tayong iba't ibang mga device na ginagamit sa mga bata. Kasi 93%, so definitely that's low. Tapos nagre-retract. Tapos RR 55. Okay, yung pinakasimple na ibibigay natin para magkaroon.
Sa cannula. We have a nasal cannula for
of course. So, that is our message to our interns here, no? You have to be aware of the different oxygen delivery devices. Well, at least for pediatric patients, may tinatawag tayong low flow, high flow. Yung low flow, pinakasimple na, nasal can. Okay?
low flow.
Yeah, from 1 to 4 liters per minute. Okay?
5 LPM na, at least mas madapat.
Yeah, beyond 4 liters, the oxygen there, yung delivery becomes very irritating to the nasal mucosa. The next one, step up hierarchy pwede ka nang gumamit ng face mask. Again, after 15 minutes, 20 minutes of assessment whether the patient's O2 sat is improving and the patient's overall respiratory condition has improved, baka pwede na siyang hanggang mask lang or hanggang cannula. Ang key there is for every intervention, reassess after. Okay, so yun yung importante doon. Lalo na sa mga respiratory distress, be ready to provide and to stabilize the airway. Sige.
Thank you very much, Ma'am Rubino, for those insights. Sige, tama. Very talagang quick lang kasi important lang take home away doon. Hindi lahat kailangan makuha nyo ganyan ka-detail na history at the very onset. You can always go back to patient. Same with adult, no? You don't have to get the very detailed history. Yung mga pertinence lang, and then you can always go back to get the other contributory details for our patient. Now, let's see the diagnostic results. For the CBC, Dr. Rubio, can you interpret this? Interpret the results?
So you have here we have normal platelet count, have here increase in the WBC count. So we have leukocytosis with neutrophilic predominance. So that could be a sign of having a bacterial infection, as mentioned earlier.
Okay. Kasi sa PE kanina, it was noted that there's some pallor. Is a hemoglobin of 110 normal for the patient?
To be honest, I'm not quite sure the range of values for the pediatric. I'm more familiar with the adults, but generally less than 12 points to a low already puts to anemia already. Correct me if I'm not wrong to our pediatricians. Sorry. I'm more familiar with the adult range.
Sige, I think parang sa PEDIA 95 to 100.
Okay.
To be honest, there's a table for that even I do not
Ako din,
memorize.
hindi ko alam. Kaya I'm asking for comments.
Pero for eyeballing, for the purpose of eyeballing, yung 110, pwede pa.
Pwede pa, okay.
Would you agree, Ma'am Ruby? Sa akin, pwede pa yung 110.
Oo, yes, pwede pa. Pero if it's 100, 500, yeah, that's mild anemia.
Okay, sige.
Thank you po.
So, important to take note here is the WBC predominance, the elevated WBC with neutrophilic predominance. So which, as mentioned by Dr. Rubio, could suggest a bacterial infection. Next.
So, dagdag ko lang
Go
din.
ahead,
Again,
Dadagdag lang din ako for the board exam purposes.
Good.
Go back previous slide, Denver. Please be aware that in the board exams, they want you to know the normal values already. They don't provide reference values, reference tables, compared to pre-pandemic. Pre-pandemic, pag may question, may may table kung normal, malalaman mo kung normal or abnormal. Lately, wala na. So, we provide you with that. Okay, sa top-notch din naman pagdating sa boards, yung IM and PEDIA team, may mga normal values na naka-indicate na. But I want you to be aware of that as early as now. You will need to know this for those normal values for your boards. Dahil yun yung trend. Continue.
yeah. So again, guys, be familiar. Yan, tama, yun yung sasabihin ko with Broly, with the normal values. Pediatric patients have a very different normal values, even for the WBC. For an adult, 19 is extremely high. Tama, di ba, friends? Mataas yung 19 sa adults. Pero for a 3-year-old, yung 19 ang cut-off depending on the reference that you will be checking. Sa 3-year-old hanggang mga 17, 16, pwede pa yan. So 19 it's elevated, but hindi siya yung sobrang taas. For a newborn, yung 19 normal pa yan. So my point is, yun nga, there are different ranges for normal values in adults and in PEDIA.
Okay. Ito sabihin ko yung favorite line ko pagka nasa PEDIA rotation. Children are not little adults, so you really have to check your tables. No, I know it's very difficult, but kaya ako nag-adult nag-IM, nag-cardio kasi hindi nagbabago yung dose of medication once the patient is adult. Sa Korea lang pagka meron ng liver or kidney problem, doon lang kami nag-a-adjust. But for them kasi it's really based on the weight, based on the age, in different cutoffs for these parameters. All right, next. Sa CBG, the result is can you comment, Dr. Rubio?
Relatively low yung CBG range niya. If it goes beyond less than 70, you will really have hypoglycemia for the patient.
Again, I'm not sure, no, as an adult, I'm not familiar with the normal CBG range for a 3-year-old. Ma'am Ruby, Dr. Ian, is this acceptable pa yung CBG na to?
Normal.
Normal.
yan. Normal yan.
100 pa naman, so normal.
Same, ang lower cutoff din, 70, 80, depending on the reference. Around 70, 80. And more on sa PEDIA rin kami. Yun yung mahirap kasi with PEDIA. Wala, even different references would have different cutoff values So we always pa rin correlate. So for example, yung CBG mo borderline 70, 80. Pero yung bata masigla, active, gano'n. Edi okay lang, huwag mo nang patulan. Pero yung CBG mo 70, 80, yung bata dehydrated, tapos nagsi-seizure, or talagang hindi gumagalaw, tamlay na tamlay, then probably kailangan mong patulan. Parang gano'n.
Okay, thank you. So important lang, no, don't treat the numbers, treat the patient, correlate clinically. Next. So the electrolytes are shown, no? Sodium is 138, potassium 3.5, calcium is 1.15, and chloride is 100, all within acceptable limits. Next slide. The ABG, not done or hindi daw available. So these are real life scenarios that really happens. No? Talagang may mga incidences na hindi available yung ABG. Next slide.
Ano lang, for the sake
Question.
of, for discussion purposes, Doc Prince, if the ABG were done, very quickly lang, what would you expect? What result would you expect for this child?
The primary would be a respiratory alkalosis since we have takip niya in this case, so it will blow off the carbon dioxide in the body, leading to respiratory alkalosis.
Agree. So, ako isipin ko it's either that, because of the takip niya, you could have respiratory
Pwede ka rin
alkalosis,
magkaano, metabolic din na
pwede rin acidosis.
alkalosis, yes. Kasi infection.
Because of
as well.
the infection. Yeah. Alright.
And hypoxemia. Siguro, may konting hypoxemia.
Hypoxemia as well.
Sige. Okay, next. Chest X-ray, I don't think we have the available plate, but there are note of white densities, no? I think these are reticulonodular infiltrates with consolidation at the left lower lobe. Briefly, can you comment on that? Prince, are these expected findings for a patient with?
Yes, these are actually expected findings having pacifications. These are actually signs of having edema or localized edema or infiltration in the patient's parenchyma. And with that, it's noted that there are no other complications such as pneumothorax, wala mga abscess formation, there are no effusion present. So these are actually important negatives in the patient's chest X-ray.
Doc Broly, do you have any questions for Prince correlating it to the pathophysiologic mechanism of pneumonia?
Can you tell us about gray hepatization and red hepatization? Refresh our memories, Prince. That's another common board exam topic for PATA.
So pneumonia in general is actually the response of the lungs to an agent, to a foreign body, to a foreign material, to an etiologic agent. So there are actually 4 phases of pneumonia pathology-wise. First is we have the edema stage, wherein there is the release of interstitial fluid from the interstitium going to the patient's alveolar structure. So nagkakaroon dyan ng mga exudative proteinaceous na material along with bacteria in the alveoli. Next, transient lang naman yan. Next is your red hepatization phase. During the red hepatization phase, nagkakaroon tayo dyan yung parang consolidation of the patient's lungs, and this time by pathology, kulay red siya. Kasi it is actually rich in erythrocytes that are extravasating into the alveoli of the patient. Eventually, these red blood cells will be degraded and lyse afterwards and will be replaced by your gray hepatization. This time, there are no new erythrocytes extravasating into the alveoli. Nagkakaroon tayo dyan ngayon ng predominance of neutrophil. Neutrophils are the first responders, okay, after the release of chemokines from the site of infection. So, tatawagin yung mag-march yung ating neutrophils coming from the blood, going to the alveoli, replacing the RBCs with your neutrophils. Kaya magkakaroon ng gray in colorization kasi white blood cells in general, di ba? Parang nagkakaroon ka dyan ng abundance of neutrophils in the process. And lastly, we have the phase known as the resolution phase. In the resolution phase, there's the clearing of the debris, clearing of the bacteria, clearing of the RBCs, clearing of the different neutrophils. This time, ang natitira ay macrophages mo. Macrophages, these are derived from monocytes and they will cause the anti-inflammation process. They will initiate anti-inflammation afterwards for repair and the solution of the patient's lung problem. So those are the 4 phases of your pneumonia. Again, pneumonia is the response of the body towards a bacterial infection, to a bacteria or a foreign body or a microbe.
All right. Thank you very much, Dr. Rubio, for refreshing us on the pathophysiologic mechanism and correlating with basic pathology on the on pneumonia. Galing talaga. Next slide. So RT-PCR, of course, I think it was negative. back tayo. Yan, negative, no? Negative result. So given these are the only available labs for your patient, ano, I know you have requested for the ideal extensive labs, no, that are be done for the patient. But based on the results of the labs, based on your history in PE, give us your working impression for this case.
Sorry. For based on the patient's history, physical examination, and even the labs given, patient is diagnosed for having pediatric community-acquired pneumonia, and I agree with the classification. It is at the PCAP-C or at the severe categorization. At the same time, we're still considering here a case of possible bronchial asthma, not inacute exacerbation, since we cannot totally rule it out at this stage for the patient. So that will be my primary diagnosis for this case. My working impression right now. Ruled out na ating COVID-19
Okay.
infection.
Based on that, based on your working impression, how will you now proceed with the management? So from the ER
Yes.
down to where you will admit the patient. Sige, go ahead.
So that is why we actually need to categorize your PCAP, because it will actually help us in triage of your patient. Kasi for those PCAP A and B, they're generally sent home and given antibiotics orally. But those patients with having PCAP C, for example, these are the patients who can be admitted at the ward. Those with PCAP D, which are very severe in categorization, will be admitted at the ICU. So for this patient, I will admit patient at the ward. Then I will perform monitoring vital signs every 4 hours, monitoring of the INO every 4 hours. I will perform here insertion of nasal cannula. I think I would start with at least 1 LPM muna. Then check and reassess every time I increase the patient's auto support if we need to reassess furthermore. There is no need for intubation in this case at this point, since there are no signs of apnea, there's no signs of grunting for the patient. Patient is still awake and not in hindi pa siya talaga tulog-tulog to the point na wala na siyang enough na consciousness at this point. So that will be my primary line. In line with my diagnostics, those are the things that I'm going to do. Furthermore, of course, we need to perform the loading of the different medications. So for this case, since we may start patient on fluids. Since meron tayong upper oral intake, I will choose a D5 containing fluid and perform holiday cigar computation of the patient's based on patient's weight, kung ano yung aking magiging initial na maintenance fluid for the patient. Kailangan D5 siya kasi per oral intake siya. So you need to have a source of glucose habang hindi siya nakakakain. Furthermore, I would load an antibiotic for the patient. So for this case na PCAP C yung ating pasyente, PCAP C. So of course, antibiotic is warranted already. So for PCAP C, those requiring hospitalization, okay naman kasi yung kanyang primary immunization at this point. So I may start patient. Sorry. I have forgot if meron ba siyang Hib vaccination. Can I check lang po?
Meron.
Kasi di ko matter yung kanyang if we have H influenza na vaccination kasi,
Meron.
you may start patient on penicillin G for the patient. Pero if wala kang Haemophilus influenzae B na vaccination kay patient, you may start patient on ampicillin as a primary drug of choice.
So friends, you mentioned na tama yun. Very important in deciding for your antibiotic empirically for this patient would be the immunization. Aside from that, ano pa yung isa na very important factor na would determine what antibiotics you will start for this patient?
Yung age din ng patient natin, at the same time,
isa pa.
yung categorization ng kanyang severity, saka if kaya ba niya mag-oral intake or not. In this case kasi hindi niya kaya, so we need to start on IV antibiotics muna.
But also you have to ask friends if there's previous history of antibiotic usage.
Yes, of course.
So yeah,
Previous
that's
antibiotic,
very
of course.
important. So yan, tama yung sabi mo na penicillin G or ampicillin would be a good starting point depending on the vaccination status. But do not forget also if meron siyang previous antibiotic usage.
So, sorry, hindi ko maalala yung kanyang vaccination status. But
Meron,
either those
complete.
meron siya. So it means can start patient ng penicillin G. And assuming na wala siyang antibiotics for the past 3 months, we have lower risk for MDRO organisms. So with that, tapos I'm not quite sure with the pediatric population, but if there's wheezing present, we may start patient on nebulization as well. Para magkaroon ng better aeration of the patient's lungs.
I think important din talaga ang bronchodilators kasi there's
Yes.
actually wheezing. Baka once you nebulize the patient, no, the desaturation mo also might have improved. And of course, it will also improve the expectoration, no, of the patient. Other than that, anything else that you would, how about mucolytics? Do you give your patient with mucolytics?
Yes, we may also give the patient mucolytics as well. Hindi naman tayo naka-antitussive sa kanya. We can't give them in combo with antitussives kasi magkakaroon ng retention in the lungs. So in this case, we can give the patient mucolytics as well. So we may start patient on NAC tablets at least twice a day for the patient.
Okay. So yeah, just to review your therapeutics, you would start either with a penicillin G or an ampicillin. Then
Penicillin G, in this case, I would start with penicillin G since patient has a previous history of Haemophilus influenza B vaccination and there is no history of previous antibiotic use for the past 3 months, rendering patient to be less likely to have MDRO pathogens.
Then you mentioned that you'll give bronchodilator nebulization
Yes,
with
PEDIA as well.
what would you
And
give?
oxygenation fluid as well.
What did you give for your nebulization?
Since in this case, I would since if we're considering an asthma here, good to provide salbutamol for this patient. Since beta agonists are the ideal drug of choice for those who are in acute exacerbation for asthma, since they are beta agonists.
Would you consider giving is a steroid appropriate to be started for this patient kahit nebulization?
In this case, steroids are not of has no given benefit for those with having asthma. In contrast, but in this case, steroid is also not will provide which has infection, so this could actually cause patient to have increase in severity of infection. Baka mas lumala pa kasi you are inhibiting the patient's defenses.
Okay.
Sige, okay, pwede ba mag-comment, Bye?
Go ahead.
Yeah. So first comment regarding dun sa mga mucolytics, mucokinetic agents. Well, actually, again, this will depend on the preference of the attending physician. Pero if we will base it strictly on guidelines, your mucolytics, your mucokinetic agents, they are not really recommended. For the very simple reason na in children, wala pang studies that prove that they are really beneficial. Tapos, there are some literature na will state that yung mga agents na yan for very young children, medyo narrow yung therapeutic window nila. That's why ang guidelines, they would recommend na hindi sila part ng routine management for pneumonia. Okay? Pero yun nga, sabi ko sa inyo, disclaimer nung statement ko na yan is it really depends on the attending physician because I know a lot of pediatricians who use mga carbocysteine, mga other disodrine, mga ganyan. Ako personally in my practice, I do not. Okay? So that's one. That's number two. Very good question yung question ni Dr. Denver, Doc Friends. Would you be starting steroids at this point? And to be able to answer that, tanong ko sa iyo at this point, how much are you considering na merong asthmatic component itong batang to? Diba? Kasi if you're really convinced na this is simply pneumonia and that's it, then probably tama ka. Probably you wouldn't need to start your steroids. Pero if at the back of your mind, this is pneumonia with a possible asthma na na-exacerbate, di ba? Then you should be starting your steroids because that's part of the management of asthma exacerbation, di ba? So to be able to answer that, yun nga, babalik ko sa iyo yung question, Doc Friends. At this point, are you still thinking of asthma? Pag sinabi mo hindi, that doesn't mean na zero. Pero do you think that this patient likely or unlikely has asthma?
For me, the chance of having asthma here would be less likely for my case, since we could also have wheezing from hyperactivity of your airways from the pneumonia actually. Patient has no prior history of having asthma prior to the patient's illness, assuming patient is clinically well prior to the patient's illness. So, kumbaga, sana yun yung mas presentation niya sana muna. Tsaka in the case kasi given kanina, nagkaroon na siya ng mga night cough and sweating ng bandang latter stage of the infection. So, asthma having it na night or umaga na chronically. So parang for me, still can be hyperactivity of the airways as well. Pwede ba rin because of that?
So I'll just share my quick what I use personally in the clinics, and ito yung turo ng mga consultant sa amin. So what are the things that will point to a possible high probability of asthma, especially in children na mahirap nga silang i-diagnose? Number one is a family history. Always ask, may lahi ba yung mother or father na asthma? So pag may parents niyan mataas yung probability na may asthma, then probably baka point for asthma yan. Number two is the chronicity of the symptoms. Sa GINA guidelines, they would tell you that infantile asthma or even asthma in patients less than 5 years old, usually these symptoms should be present for at least 6 months. So recurrent symptoms yan for at least 6 months. And number three, the pattern of the cough. So asthma, not all, pero in general, in children, they're worse at night. So very important yung nagigising yung bata sa gabi, madaling araw. So early in the morning, nagigising dahil sa ubo. And they're usually triggered by activity. So ito yung mga batang pag tumakbo, pag umiyak, pag napagod, dun sila hinihingal. Okay? So if you do get those in your history, so may lahi, for the past 6 months, on and off, ubo ng ubo, tapos nag-respond pa sa SABA, and then mas malala sa gabi, tapos mas malala pag napapagod yung bata, pag tumatawa, umiiyak, then probably you would consider na baka may asthma to. So for this case, yeah, I would have to agree. I don't think this has a asthmatic component, and I don't think steroids are warranted.
To add din pala, for the therapeutics, thank you din by dun sa guide na yun. To add din pala dun sa, I think pwede na tayo mag-start tong zinc supplementation ng kay patient. As I've recalled in the pickup guidelines, it has actually benefit for mortality reduction. So we can also supplement that siguro if patient would have oral intake already after a few days.
May I add also?
Go ahead, Ma'am Ruby po.
Na-mention nga kasi dun sa past medical history that there were three episodes, prior episodes of having cough, and apparently the child was just nebulized at home with salbutamol, and the history stated there was apparent relief, no? I forgot kung merong strong family history of asthma, sorry, sa family history kung na-mention. So anyway, yun nga yung pino-point out nga din ni Dr. Ian, no, na dapat mahalagang makuha yun, yung family history, past medical history, the pattern of the cough. Pero ito, for this particular case that we're discussing, I would like to think that I would definitely find that those past 3 episodes significant because there was, kung totoo yun, kung makaka-elicit kayo na merong naging response to salbutamol, may improvement, no, may reversal of the bronchospasm or of the wheezing kung sinasabing nagkaroon ng improvement. Again, going back to GINA guidelines, if you are to use this, if you are to apply this in less than 6 years old, since we're not using spirometry first, we rely on symptom pattern. So bukod dun sa 6 months ng tumatagal non duration for each episode, naka-mention doon sa guidelines, has it been more than 10 days na cough, colds, and then with wheezing, okay? Because if you're going to follow it, because, guidelines are used to basically to facilitate our clinical decision making, no? Gina-guide nga tayo. Kung susundin natin yon, lalabas doon asthma suspect. It is very hard for us to label at once na, oy, asthma na yan, no? So we usually say asthma suspect, lalo na pag ganoon. A very, very good follow-up question dun sa 3 prior episodes na nagwi-wheezing na apparently nagsalbutamol, para ma-strengthen nyo lalo whether it's really asthma or not, is to ask whether sinabi na ho ba ng doktor, straightforward sa inyo, sinabi na oh, may asthma ang anak nyo. O kaya, meron na bang nagsabi before na nagko-consider ho kami ng asthma. Okay? So yung mga ganon, it also helps, no? Kasi baka naman pala, diagnose na siya before ng isang specialist, no? Na this has been just one of those episodes again na, yes, you have to be aware that indeed, viral respiratory infections are the #1 trigger for asthma exacerbations. Na eventually nga, maglilid na sa isang lower airway, lower respiratory infection, which is pneumonia. So yun lang sa akin. It is hard for us to sabihin na lalo na sa first time wheezing. But then again, one more additional clue. Go back to the chest x-ray. Titigan nyo. Yes, there is infiltrates. Yes, there's consolidation there. Tingnan nyo din kung asthma alone to, chances are flat diaphragm. Di ba dapat dome shape sa lateral view? Always request for 2 standard views, and that would be AP and lateral view. Normal is dome shape sa lateral view. Pero pag flattened na ang itsura, hindi na nakaganon ng diaphragm, hyperaeration, which means more of obstructive lung disease, which is more or less, of course, your asthma. Okay? So there's flattening of the diaphragm there. At again, possible na meron ngang kasabay na infection, kaya andun yung mga infiltrates niya. So that's how you will take a look at all of these clues that we have. Okay.
Sige lang. So based on the discussion lang, is there harm in starting or doing or giving the patient with steroids as a steroid nebulization such as budesonide?
Okay. Gusto ko lang, bago ko sagutin yon, i-mention ko lang din, dun sa 2021 PAPP guidelines, naka-mention doon, although, if I'm not mistaken, parang hindi ganun ka-strong yung evidence, no? If there is wheezing present in a patient whom you suspect to have asthma, yes, there is a benefit for giving your bronchodilator, okay? Kasi may tinatawag tayong viral-induced wheezing. Viral pneumonia. Viral pneumonia, kung virus yung talagang cause niya, it's more of wheezing rather than crackles or ralls. Whereas yung talagang classic na pneumonia, dahil nga restrictive lung disease, di ba, pag nag-inhale, yung interaction nung nag-inhale na air going through the fluid-filled alveolar sacs create the crackling sound. Kung purely pneumonia, classic yun. Talagang puro crackles lang. What if nga merong concomitant na possible asthma? So yung mga ganon, is there danger? You would be surprised, there are practitioners, Pedia Pulmo and Gen Peds na magpapabigay. Another consideration is kung mataas talaga yung lagnat, dinedefer. Kasi, di ba, kung sa steroids, kung kasalukuyang mataas yung fever, dinedefer nila. So they just stick with giving antibiotics for the pneumonia. And of course, your bronchodilator, whether it's because of viral-induced wheezing or because there is really an underlying asthma o dahil baka asthma suspect na siya. Okay? But for steroids, it would differ. Parang, correct me if I'm wrong, Ian, baka Doc Ian, may ano ba nga sa guidelines ng ng steroids regarding
Ito, Doc,
fever?
nasa harapan ko nga ngayon eh.
Ayan. Oo, ayan.
Parang ang sabi dito, maybe beneficial yung oral steroids pag may coexisting asthma. Sabi dun sa may not be beneficial yung parenteral steroids if the patient is without asthma. Pero wala rin silang nakasabi dito. Nandiyan din sa pickup C, sabi dito steroid may be beneficial in reducing the length of stay. Pero sabi rin dito yung parenteral steroid may not be beneficial. So medyo malabo pa. Hindi pa clear. Pero actually, that's really a good question. We were in discussion with one of my PICO friends a few weeks ago about steroids, the role of steroids. Kasi even without the guidelines, napansin niyo rin siguro Doc Ruby, lalo na sa mga pangit na pneumonia, may maraming gumagamit ng off-label na steroids eh. Tapos nag-improve sila eh. And according to my PICO batchmate, there are new studies coming in na mukhang may role nga talaga yung steroids for severe pneumonia, lalo na pag may mga hyperactive airway component. So ako, if you will ask me, Dr. Chongson, if makakasama ba based on experience, most of the time actually wala, bihira na nagkaka-problem eh. So siguro if I were at a crossroad na hindi ako sure kung magbe-benefit ba or hindi, tapos pangit yung pasyente, for example, for this case, for example, I tried giving oxygen support, tapos I tried giving my doses of nebulization with salbutamol, and then after that, ang pangit pa rin ng air entry ko, nagwiwisis pa rin siya, tight pa rin, then I might consider giving steroids even if I'm not really sure if it is asthma or not.
I would also give. In fact, pag nagbigay ka naman ng steroids sa ganitong clinical scenario, short course lang naman eh. So, you're not giving it for long term. So, yes, we give it eventually.
You won't probably run into to major problems.
Okay. The reason why I ask kasi, the patient has wheezing, then definitely it has obstructive airway. When there's wheezing kasi, there's narrowing of your airway, most likely in the small to medium-sized airway, your bronchioles. Pneumonia is primarily more often than not involves the alveoli. So the reason why I ask, because in adult practice, for patients presenting with pneumonia that we're highly considering asthma, we give steroids at the very onset, kahit isang IV plus parenteral, IV and steroids through the nebulization. So just to give a controller already for the inflammation, for the hyperreactive airway, and of course we give the reliever bronchodilator lang dun sa patient. And of course, the reason we always remember to treat the underlying cause, what triggered the exacerbation, and that is to give the patient with antibiotic treatment, because particularly in this case, the patient had pneumonia. So that's the reason why I ask, kasi I'm not sure how is it approached in the pediatric population, but in the adult, we give it at the onset if we're considering a high-risk pneumonia on top of a possible acute asthma exacerbation. As a matter of fact, if we're so feared, kasi baka lang nagugulo yung students, why are we discussing if there's harm in steroids? Remember that steroids are actually immunosuppressants, They act on the white blood cells. So particularly if you give an immunosuppressant for someone with an infection, that would of course inhibit your immune response, and the infection might overwhelm. But for patients with severe sepsis, those with severe refractory shock, we actually give steroids. So it's actually there's no hard and fast rule when you give it or not, but you always have to consider the clinical picture, the clinical profile of the patient, and of course guided by the guidelines, guided by the recommendation. That's the reason why I asked them. Very, very nice answers from both Dr. De Vera and Dr. Punong Bayan. We always cite studies. There's no significant study to support for or against the use of a specific something. Kapag ganun kasi, nando ka na sa gray zone. Mag-rely ka na sa expert opinion and sa experience. So, anything else? Any additional in the management? So, basically, we are dealing with PCAP, pediatric community-acquired pneumonia, type C, which is moderate to severe in your language. And then we have given maintenance fluids, antibiotics, which are the either penicillin G because the patient has vaccination and there's no recent antibiotic use. We have given bronchodilator at the very least, no, to relieve the wheezing of the patient. And where should we admit this type of patient? Dr.
At the
Ruby.
ward, at the level of the ward, at this point, we don't have any need for use of invasive ventilation at this point. So we ICU management is not yet warranted.
Okay. Do you agree, Dr. De Vera? Dr. Panambayan? That can this be managed sa ward lang?
Yes. The considering also the overall sensorium of the child, okay? Pwede naman, no, sa ward. Unless talagang lethargic, obtunded, stuporous, because one of the parameters that we consider in the severity, no, becoming very, very severe is of course the level of sensorium. If you recall, one of the parameters also in that guideline is yung signs of hydration, whether alam nyo naman pag dehydrated. So importanteng tanong pa pala to, ha, kailan huling umihi? For the past 6 hours, walang urine output, then put it together with the depressed sensorium. Yes, baka very severe na talaga together with all of those respiratory symptoms, then pang ICU siya pag ganon.
Okay.
In other words,
With-
the more numerous the severe manifestations are, yes, the patient would end up being admitted in the ICU. Sorry, Ian, go ahead, please.
Okay lang daw. With regards to the fluids lang pala, ako probably I might hydrate this patient. You mentioned, Dr. Frins, na naka-maintenance, no? Meron kang some signs of dehydration. Medyo dry yung lips niya, tachycardic, and then poor intake pa. So probably might hydrate this. Pero plus or minus naman yun. Also, yung urine output, very important. If this patient had no urine output for a long time, then I would probably give fluids na non-potassium containing. So you also look at that, take a look at that.
Okay. What's the target urine output sa inyo? Is it, sa amin kasi 0.5
One.
cc per hour. To
Sa PEDIA is 1
okay. 1 cc per kilo per hour.
per hour. Yeah.
All right, sige. Now, important question. What is the natural course? When we admit this patient to the ward, how long are we expecting this patient to stay in the wards? And what would be our usual criteria for discharge? Do we usually complete the antibiotic course for how many days? Or can we step down to an oral medication and send the patient and can the patient be sent home as long as the set parameters are achieved? Any of our pediatricians can answer.
Sige. In general, 48 to 72 hours is our observation period wherein we would expect response from the initial antibiotic. Unang nawawala ang lagnat, huling nawawala ang ubo. Another important parameter to say whether the patient is improving indeed is maganda na ba ang kanyang appetite. And again, the level of sensorium from being tulog-tulog, drowsy, or maybe irritable. Pag nag-rounds ka ng day 3 meds, naglalaro, may hawak na gadget, nonood ng TV, nakasmile sa'yo, yung mga ganon. And compare it to the baseline sensorium prior to admission, then yes, you would say the patient really has improved. Step down, usually, rational drug therapy dictates that whatever the initial parenteral antibiotic was used, you go for the equivalent oral antibiotic. Okay. 72 hours would be a good observation period. And then we decide to step down to an oral form. Okay. Dr. Ian, in addition to that, ano pa ba?
Yeah, I agree, Doc. Yun din yung ano ko. Very important yung sensorium oral intake ng mga bata. Kasi sometimes wala na silang fever pero hindi pa rin kumakain. And then sa step down, we also, for practical tips, you also consider syempre yung oral medications, yung preparation, yung lasa. So kung minsan kasi, for example, in the, kunwari, you started the patient on IV cefuroxime, ang pangit ng lasa ng cefuroxime na oral talaga eh. So, Kasi defeats the purpose na ano, okay na yung pasyente mo tapos pinauwi mo hindi pala niya nainom yung gamot. So you have to make sure na you have to instruct the SO, the parents really well na ito yung gamot, nag-improve na yung bata pero we have to complete the medication. So dapat ma-complete nila yung duration which is around 7 days na naiinom yung antibiotics. Because ako in my practice, I do get that from time to time na na-discharge ko na okay na then only to come back after a week, worsen yung case. And then when you do your history, hindi pala nainom. Bakit hindi nainom? Ayaw daw ng bata. Hindi na sila bumalik. Mga gano'n. Practical tips.
Dahil palang ano, no? Kaya ako hindi ako nag-pedia. Yung dami iniisip. Anyway, any other thoughts? Anticipatory care, Dr. Rubio, for this patient. You're able to discharge the patient.
If
Non-pharmacological advice
if-
to the
yes.
parents.
So one, definitely vaccination is very important. So we have to review the patient's vaccination history as well. So if wala siyang HIB vaccination, we must provide that. Then we must provide patient at least PCV vaccination for the patient na conjugated vaccine. Make sure na meron siyang vaccine for HIB, for diphtheria, for pertussis, as well for measles and varicella. And of course for influenza, I guess parang wala ata siyang annual influenza vaccination. And parang I believe wala siyang Japanese encephalitis na vaccination as well. So we must complete the patient's vaccination per age per month. Tapos you must also advise na proper nutrition, of course. Tapos avoid patient on exposure to smoking, to biomass fuel, burning, kasi if talaga meron siyang asthma, it could trigger other asthmatic events as well. And of course, smoking will also contribute to a risk factor for pneumonia as well.
May I add?
Go ahead, Dr. Rubio.
Importante yung sa vaccination, no? Kung mapupunan natin, naka-mention lang doon yung first year of life. Doon sa immunization history flashed earlier. Yes, complete, pero up to 12 months of life. So, importanteng tanong ha sa parents, saan ba sila nag-avail? Health center or private practitioner? Private practitioner, somehow you are assured na natutuloy because you all know that vaccinations does not end at 12 months of life. There's beyond EPI, beyond the first year of life. At dahil 3 years old na siya, walang na-mention na booster shots of the primary series, we would like to presume na baka kulang, inadequate pa. So dyan papasok yung anticipatory guidance na yes, you should avail of. Sadly, ang DOH kasi talaga natin, ang coverage nila hanggang 1-year-old lang. But we can always advise them to go to a private practitioner para maka-avail at i-emphasize natin na yung prevention pa rin of all of these communicable diseases ay dapat. Tandaan, ang inactivated vaccines, yung mga DPT, HIB, pneumococcal, bumababa ang antibody titers over time. Kaya nga kailangan nila ng booster shots yung mga inactivated vaccines. So yun, very important to emphasize.
Can I share a screen, Mai?
Go ahead.
Yeah. Tawag nito. Yun, very important yung sinabi ni Doc Ruby na for the students siguro sana maano niyo in practice when you're dealing with pediatric patients. You have to emphasize with the parents na kulang yung vaccine sa health center because a lot of parents will think na kompleto na yung health center. Pag tinanong mo sila, they would proudly say, kompleto po yung bakuna ng anak ko. What actually I tell them is, never po tayong makokompleto. Because even, for example, flu. Every year ang flu vaccine, di ba? So technically, walang term na graduate na yung bata sa bakuna. Okay? So for the students, I would like you to take a look at this. Please do download this. It's readily available online. It's the PPS. Nakikita niyo ba? Immunization schedule.
Yes, nakikita.
Yeah, and actually everything that you need to know is here. Even not everything, 90%. The nitty-gritty is here. For example, for this patient, if tama yung nasa papel na binasa ko sa case, wala pala siyang pneumonia vaccine. So for example, gaya niyan, so wala siyang pneumococcal vaccine, paano mo ibibigay yan? 3 years old na siya. Nandiyan lahat ng kailangan nyo. The primary dose is 3 doses, 4 weeks apart. magbo-booster ka ng 6 months after the 3rd dose. Pero yung pasyente nyo, 3 years old na, wala pa raw siyang, kung tama, kung wala pa siyang pneumococcal vaccine, anong gagawin mo? Dito ka na lang. Kung PCV13 ka, 2 to 5 years old, 1 dose lang, okay na yan. So, for this patient, ito na yung susundin natin. Okay? So, please, students listening to this lecture, to this session, please download this in your phones. Take time to review. This one is the very basic schedule laid out graphically well. Pero nandito rin sa file lahat ng nitty-gritty na kailangan nyo. Okay?
Doc Ian? Oh, thank you for flashing this table. Tapos remind din natin yung mga students. Traditionally, the Pediatric Infectious Disease Society of the Philippines as well as Philippine PEDIA Society flashes or comes out with the latest immunization table traditionally and 3rd or 4th week of Feb. Di ba, remember, tumataon siya sa PEDSP annual convention. So, oo, whatever it is na may maaaring may a little
Changes.
modifications, usually naman little modifications na lang, pero what you saw there in the slide, yun na yung basic talaga. So some modifications, we will know that usually 3rd or 4th week of February of each year. So yun lang, at downloadable ito for free.
Baka for this year, ma'am, baka meron na yung COVID, no? Baka maglabas, isama na niya.
Remember,
Yung
di
COVID
ba mga
vaccine.
nakakaraang taon, may dengue vaccine doon, tapos tinanggal nila nung nagkaroon ng
Tinanggal.
issue.
Came back siya.
Yeah.
Okay. I guess because of our time limit, I know marami pa tayong pwedeng ma-discuss at ma-share but given our limited time, we have to wrap up. Maraming salamat po Dr. Punong Bayan and Dr. Ian De Vera for actually
From
sharing
audience, baka may questions yung audience.
Ay, sorry.
Pala, kalimutan ko.
Are there any questions pala to the audience? Sorry.
So you can unmute yourself, guys, or you can place it on the chat group. Sulitin nyo na, nandito yung mga PEDIA natin, tsaka nandito si Fritz.
Hello, good evening. May I ask the questions here?
Okay, go ahead.
Yes.
Okay, hi. Sige, for writing nasagot na tanong, good evening. For writing the diagnosis of PCAP, is it necessary to specify PCAP A to D in addition to severe or non-severe? Or should it just be written severe or non-severe without specifying the A to D?
Usually kasama yon. Why? Lalo na kasi sa PhilHealth reimbursement. Di ba no, Doc Ian, bilang owner ng hospital, importante yon,
Tapos
no?
actually, ang isasagot ko din dyan, ma'am, is depende sa institution. Kasi yung nomenclature, it changes really fast, di ba? Dati ABCD, mild, moderate, severe. Tapos ngayon, naging dalawa na lang, non-severe,
Dalawa
tas
na
severe
lang.
na lang. Yeah, my tip for the students is to know the nomenclature, the most recent ones, because probably in training institutions, that is what they will ask of you. But also to know the past nomenclatures for the purpose of kumbaga, mga nice to know facts. Kasi a lot of times may mga use pa rin yung old nomenclature. So gaya yan, ABCD, if you go strictly speaking with the PAPP guidelines, hindi na nila ginagamit yung mild, moderate, severe. Ano na lang sila? Non-severe, saka severe, parang ganun. Pero yan, it's better to know, lalo na pag nasa intern, clerk, residence level, mas maganda na sinusunod natin yung guidelines saka yung mga nomenclature na pag-name sa kanila.
Huwag silang malilito. Yung 2016 guidelines, A, B, C, D. A and B, non-severe. C, severe. D, very severe. Fast forward, 2021 guidelines, non-severe and severe na lang. Pero kung makikita nyo, yung severe na latest, basically yun din yung nag-overlap na dun yung severe and very severe. Yun lang yun. Tapos again, sabi nga ni Doc Ian, no, lalo na sa mga institutions na training institutions, usually they would ask really academic, theoretical, yung latest guidelines. Pero sa sa government institutions, halimbawa sa Ospital ng Maynila, sa PGH, pag nagsusulat ng yung final diagnosis, hinahanap pa rin sa amin sa PhilHealth, bumabalik yung chart yung napuntahan ko na, bumabalik kasi hinahanap nila yung 2016 guidelines. Their explanation is apparently parang hindi pa na-apply dun sa PhilHealth yung 2021 guidelines. Kaya ang hinahanap nila sa categorization para
Mild,
din sa
moderate.
dun sa appropriate na reimbursement yung A, B, C, and D. Yun. Pero yun yung 2016 guidelines. So, pero otherwise, halos nag-overlap na yung manifestations talaga ng severe and very severe dun sa current guidelines.
Another question here. Sorry, it's a question that I, as a mom, also have. So thank you for my free consult here, docs. What age is ideal to teach children to drink tablets instead of syrups, or does it just depend?
Walang special age na na-mention yan sa textbooks or even sa guidelines. But from a practical point of view, number one consideration is if they are developmentally ready for that. Magugulat tayo, may 10 years old, 12 years old. So sabi, Dok, syrup na lang, di pa namin kaya tablet. Mahirap naman pilitin. So, but if Arabella can tolerate tablet at this age, why not? Pero to answer, wala. Ian, Doc Ian, meron ba? I don't
Wala,
think
Doc
there's-
Wala. It's really siguro definitely very young children, we wouldn't attempt because of the risk of choking. Pero pagdating na dun sa, kunwari, nakakausap na, marunong na-instruct nyo na, marunong na mag-gargle, pag nagtututbrush sila, they know how to control their muscles, okay? Depende na talaga dun sa capability ng children. Ako, I've had patients na, for example, 8 years old, 7 years old, tinatanong ko pag kaya na, and then magugulat kayo, sabihin naman parang kaya na, ganun. Kasi I'm not sure, Doc, if same experience with you, with me, kasi kuminsan, lalo na pag medyo mabibigat yung bata, mas mura pag tablet lalabas yung cost, mas mura on the economic point of view, mahal yung mga syrup Kaya yun, tinatanong namin, pa rin wala siyang hard and fast rule, depende dun sa bata.
Guys, please don't send your questions to my Viber. Please send it here sa chat box. I can't check my Viber.
Okay, any other questions? You can PM kung nahiya kayo sa chat. You can send it privately.
Hold on.
Hi, good afternoon, doctors.
Hi.
Perfect.
Hi, I am currently a PGI here in a private institution. So during the entire discussion, we were able to discuss a lot of criteria and a lot of guidelines as well. So for the purposes of board exam, doctors, what do we usually follow? Do we follow the guidelines that are updated every year, or we really follow the major reference of the book, like for example, Nelson's? Thank you.
Good question. Roddy?
Hirap sagutin.
Laging ganun.
Textbook or ano yung choices?
Clinical guidelines.
Guideline.
CPGs are not used in the board exams.
Yeah. I would say Nelson.
It's never been used. So you use the CPGs for your own clinical practice, for internship, clerkship reports. But for the boards, guys, it's parang basketball versus football. It's a different sport. So you have to actually prepare 2 ways for the boards. You prepare for the life thereafter, meaning yung kailangan mo talaga for clinical practice. And then you prepare yung mga talagang medyo gulang moves na kailangan mo for the board exams. It's better. The recommended reference for the med boards will vary according to the subject. What we personally noticed right now with the latest incarnation of the Board of Med, with the exception probably of PEDIA and a few other subjects, they're not using textbooks so much. PEDIA actually yung pinakamatino sa board exams nyo, guys. Dahil Nelson's base tsaka mga must-know cases ang tinatanong. Okay? Problematic right now for us and for everyone in the boards is patho, anatomy, and prevmed. Those will probably be the most difficult subjects that you're going to have, assuming that they retain the same members of the Board of Med. But that's for another day. Right now, as clerks and interns, your focus should be on how to be a very good intern, a very good clerk. So this Guazon session, i-maximize nyo. Yung binibigay sa inyo na Genesis, yung mga materials, video lectures natin dyan, i-maximize nyo. Because the best way to prepare for the boards is not really the day after your internship. The best way to prepare for the boards, day 1 ng med school, and to be capped by your clerkship and internship rotations. Okay?
So just to cap what Dr. Banzuela said, no, for the rounds, for your consultations and your conferences, pag tinatanong tayo ng consultants, ganyan, it's best to be familiar with the CPGs. But for the boards, we go back to the basics. It's always safe to go back to Nelson's and the books. Okay? Any other questions, guys? You can unmute and put it in the chat box. Don't send it to my Viber. My Viber is nakababa ngayon so that we can concentrate fully on the Guazon. Last call. You can send it to me. I'll send it. I'll ask it. Okay, here we go. Sorry, Doc, not sure if this was discussed kanina. Doc Prince mentioned zinc supplementation, but in the PEDIA main lecture, it says that zinc supplementation does not have any effect in shortening recovery time. What is the final stand on this?
Ako personally, I think there's no such significant evidence to suggest there is actually benefit in zinc supplementation. For the adult, I think also for the PEDIA is similar. Dr. Ian, Dr. Ruby?
Yeah, similar with the pediatric patients. Yung mga colleagues namin, PEDIA Pulmo na nakakasama ko rin mismo sa mga institutions, halimbawa galing sa ER, no? Tapos i-endorse na namin sa kanila kasi pupunta na ng wards. Pag nag-uusap na kami ng mga management kung ano pa yung kulang na na-start sa ER setting, they do not actually ask us, oh, paki-add ng zinc. In other words, hindi.
Pag may mga ganyan na na question sa akin yung mga students, like ko binabalik sila sa binabalik ko sa guidelines. So yan, flash ko ulit. So ito yung sa PAPP, which is really weird kasi binabasa ko rin ulit kanina. Sabi diyan, zinc can be added pero recent studies show that it does not shorten the duration. So ang weird, no? Parang pwede kang mag-add pero di siya makakatulong masyado. So yeah, outside this PAPP guidelines, most studies will tell you na question mark pa rin yung zinc. Even probiotics, I know some doctors who give probiotics for various diseases. So there are some studies, not totally zero studies. There are some studies that will support, but overall the level of evidence is still not that strong.
But zinc and probiotics are much more being utilized in gastroenteritis cases,
Yes.
not with pneumonia.
Not with pneumonia, yeah.
Siguro kasi since it's PEDIA, if I may put a mom's 2 cents in, PEDIA kasi parang we reassure the parents as much as we assure the children. So even if wala tayong recent studies, we just give that para ma-reassure yung parents we're doing something. Anything else?
In line with micronutrients, I think zinc has more studies than yung mga vitamin C, ganon.
Yes.
So ako even in my practice, I do give zinc. Lalo na pag yung kunwari viral yan. Tapos although walang studies yung zinc, pag gusto talaga ng nanay na hindi siya papayag na uuwi na walang gamot, mga ganon. So
Yeah, that's what I mean.
medyo mas maraming evidence ang zinc as compared dun sa mga traditional na ginagamit na mga vitamin C, multivitamins.
May guilty mom kasi dito. Sorry. Any other questions? Last calls. Going. Thank you very much. Floor's closed.
Okay na? Wala na, Rock. Okay, all right.
Okay,
Again,
thank you so much, everyone.
Really.
Thank you so much, Dr. Prince, Denver, Dr. Ruby, Ian, Rocky.
Thank you.
Thank you too.
Meron pa tayong mga ganito, may live sessions pa tayo for surgery and OB na parating. Tapos meron din tayong on-site na Revalida review. Okay, at the end of the
Thank you, Doc Prince.
You. May alam pa pala sa PEDIA.
O naman.
Parang IM naman siya na expand.
Okay, sige, ingat
Thank
everyone.
you.
Bye.
Thank you,
Thank
everyone.
you.